Welcome to the Empowerment Hour. I'm your host, Joss Blake, and today we're diving deep into one of medicine's most complex and fascinating frontiers, pain management. There's something almost paradoxical about pain. It's our body's most primitive alarm system, yet understanding and treating it requires some of the most sophisticated approaches in modern medicine. Today, we're going to explore this intricate world, from ancient needles to cutting-edge brain stimulation, from the simple act of stretching to complex surgical interventions. But here's what makes this journey particularly compelling. Pain isn't just a medical problem. It's deeply personal, influenced by our gender, our age, our psychology, and even our spirituality. By the end of our time together, you'll understand why a hammer blow to your finger stops hurting when you put it in your mouth, why some of the most effective pain treatments involve making you move more rather than less, and how sometimes the most high-tech solutions aren't always the best ones. So buckle up. We're about to embark on a journey that spans from the cellular level to the societal level, exploring how we can better understand, treat, and live with pain. If you're fascinated by the science of the body and mind, Scoob is your go-to AI-powered podcast studio for deep dives into health, psychology, and human connection. Download Scoob from the App Store or Play Store and start exploring today. Let me start with a story that might sound familiar. You're working on a home project, maybe building a deck or fixing a fence. Your focus is intense, measuring, cutting, hammering. Suddenly, wham! The hammer connects with your thumb instead of the nail. What's your first instinct? If you're like most people, you immediately stick that throbbing thumb in your mouth. And here's the fascinating part. It actually helps. But why? What's happening in that moment isn't just psychological comfort. It's actually a demonstration of one of the most important discoveries in pain science, the gate theory of pain. Picture your nervous system as a busy highway with multiple lanes. Pain signals travel along small nerves. Think of these as the slow lanes of our neural highway. But there are also larger nerves that carry non-painful information. Touch, temperature, movement. These are like the express lanes. Now here's where it gets interesting. These highways all converge at a critical junction in your spinal cord, and there's essentially a gate there. When you smash your thumb, those small pain nerves fire rapidly, sending urgent messages: alert, damage, attention needed. These signals race toward your brain, but they have to pass through that spinal gate first. Normally, when pain signals arrive, the gate swings wide open, and your brain gets the full force of that ouch message. But when you stick your thumb in your mouth, something remarkable happens. The pressure and warmth from your tongue activate those larger, faster nerves. These express lane signals reach the spinal gate first and essentially crowd out the pain signals. It's like having a traffic jam where the non-painful messages take up all the available lanes, forcing the pain messages to wait. The gate closes to pain, and your brain receives far fewer distress signals. This isn't just a quirky bodily function. It's the foundation for understanding why so many pain treatments work. Think about it. When you take a warm bath after a strenuous workout, you're activating temperature-sensitive nerves that close those pain gates. The relief you feel isn't just relaxation. It's neurological gatekeeping in action. But here's where it gets even more intriguing. That gate isn't just controlled by physical sensations. Your brain, that 3-pound computer between your ears, can also open and close additional gates based on what you're thinking and feeling. Have you ever noticed how pain seems worse at night when you're lying in bed with nothing to distract you? During the day, your brain is juggling dozens of tasks: work deadlines, conversations, traffic, the endless stream of daily life. All this mental activity keeps additional pain gates closed in your brain. But as soon as the distractions fade away, those gates swing open, and pain that was manageable during your busy day suddenly feels overwhelming. This explains why pain management isn't just about blocking signals. It's about understanding that pain is a complex experience influenced by both physical and psychological factors. The person who goes about their daily activities while managing chronic discomfort isn't just toughing it out. They're literally using cognitive gate control to modify their pain experience. Understanding this gate theory revolutionizes how we approach pain treatment. It's not enough to just throw medication at the problem. The most effective pain management strategies work with these natural gating mechanisms, using multiple approaches to keep as many gates closed as possible. Now, let's talk about one of the most counterintuitive discoveries in pain medicine. Sometimes, the best way to treat pain is to move more, not less. I want to tell you about someone, let's call her Sarah, whose story illustrates this beautifully. 10 years ago, Sarah was in an aerobic exercise class, following along with the instructor, when something went terribly wrong. A sudden sharp movement caused a herniated disc in her back, ultimately requiring surgery. As she lay in that hospital bed, the irony wasn't lost on her. Exercise had caused her pain, and now doctors were telling her that exercise would be the key to her recovery. The human brain is wired to avoid things that cause pain. It made perfect sense evolutionarily. If something hurt our ancestors, avoiding it increased their chances of survival. But with chronic pain, this avoidance becomes a trap. Sarah's first instinct was to never exercise again. Exercise had betrayed her once. Why trust it again? But here's what happened. About 2 weeks after surgery, when she was being extremely careful and avoiding all physical activity, her pain actually got worse. This wasn't just bad luck. It was a predictable consequence of how our musculoskeletal system responds to inactivity. When we stop moving, several things happen that actually increase pain. First, our muscles begin to weaken and lose their ability to support our joints and spine. Imagine your muscles as guy wires supporting a radio tower. When those wires become slack, the entire structure becomes unstable, and even small stresses can cause problems. Second, and this is crucial, chronic pain often triggers protective muscle spasms. These spasms made perfect sense when early humans twisted an ankle while running from a predator. The muscles would lock up around the injury, creating a natural splint to prevent further damage. But in chronic pain conditions, these spasms become part of the problem rather than part of the solution. Here's the vicious cycle. Pain causes muscle spasms, spasms cause more pain, pain causes fear of movement, lack of movement causes muscle weakness, and weakness leads to more injury risk and more pain. It's like being caught in quicksand. The more you struggle in the wrong way, the deeper you sink. Sarah discovered that gentle, consistent movement was her way out of this cycle. She started with basic stretching, nothing dramatic, just simple movements that gradually taught her muscles to relax. The first few sessions were challenging. Her muscles had become so accustomed to being in spasm that even gentle stretching triggered temporary increases in tension. But here's the beautiful part. Muscles have memory, and they can learn new patterns. With consistent practice, Sarah's muscles began to remember what it felt like to be relaxed and flexible. The stretching routine that initially caused discomfort gradually became her source of relief. The key was approaching exercise not with the no pain, no gain mentality of her old aerobic classes, but with what we might call gentle persistence. She paired her stretching routine with activities she enjoyed, watching her favorite TV shows or listening to podcasts. This wasn't just about making the exercise more pleasant. It was actually using the distraction principle we discussed earlier to help close those pain gates. As Sarah progressed, she added strengthening exercises. Strong muscles, tendons, and ligaments act as the body's natural armor against stress and trauma. When these structures are well conditioned, minor incidents, carrying groceries, getting out of a car awkwardly, lifting a box, don't escalate into major pain episodes. The most remarkable part of Sarah's journey was the discovery that became her new reality. Exercise didn't just help her manage pain, it became essential for preventing it. 10 years later, she's learned that when life gets busy and she skips her exercise routine for a week or two, her back pain returns. But when she maintains her routine of stretching and strengthening, she remains virtually pain-free. This wasn't just Sarah's experience. It's backed by solid science. Exercise works through multiple mechanisms simultaneously. It strengthens the body's natural armor, It activates those larger nerve fibers we talked about earlier. It promotes the release of natural pain-fighting chemicals called endorphins, and it provides the kind of focused activity that helps close pain gates in the brain. But perhaps most importantly, exercise helps break the fear-avoidance cycle that traps so many chronic pain sufferers. When someone like Sarah discovers that careful, progressive movement actually reduces rather than increases pain, it fundamentally changes their relationship with their body. Instead of seeing their body as fragile and unreliable, they begin to see it as adaptable and resilient. The prescription isn't the same for everyone, though. Some people benefit most from water-based exercises like swimming, where buoyancy reduces stress on joints. Others find that walking or cycling provides the right combination of cardiovascular conditioning and gentle loading of weight-bearing structures. The key is finding activities that can be sustained long-term and gradually progressed as tolerance improves. Now, let's journey from the relatively modern science of exercise therapy to one of humanity's oldest medical traditions. But don't think for a moment that we're leaving rigorous science behind. The story of acupuncture in modern pain management is fascinating precisely because it represents a perfect marriage of ancient wisdom and contemporary research methods. For thousands of years, traditional Chinese medicine has used thin needles inserted at specific points on the body to treat pain and other conditions. For much of the 20th century, Western medicine looked at acupuncture with skepticism, if not outright dismissal. How could sticking needles in seemingly random locations possibly affect pain in distant parts of the body? But something interesting happened when researchers began applying rigorous scientific methods to study acupuncture. They didn't just ask, "Does it work?" They asked more sophisticated questions. For which conditions does it work best? How does it compare to other treatments? What's actually happening in the body when acupuncture provides pain relief? The results have been nothing short of remarkable. Take chronic low back pain, for instance. Researchers developed something called percutaneous electrical nerve stimulation, or PENS, which combines traditional acupuncture needle placement with modern electrical stimulation. When they tested this approach against other treatments, including exercise therapy, conventional electrical stimulation, and placebo treatments, PENS came out on top. In one pivotal study, 91% of participants reported that PENS was more effective than other treatments for their low back pain. But the benefits went beyond just pain reduction. Participants experienced significant improvements in physical activity levels, sleep quality, and overall sense of well-being. Perhaps most importantly from a healthcare perspective, they also required fewer opioid medications. What's happening here? How can needles placed in the skin affect such a wide range of symptoms? The answer brings us back to those pain gates we discussed earlier, but with some additional mechanisms that researchers are still working to fully understand. When an acupuncture needle is inserted, it stimulates both the larger nerve fibers we've talked about and also triggers the release of the body's natural pain-fighting chemicals. But there's more to it than that. Acupuncture appears to affect the nervous system at multiple levels. Locally at the site of needle insertion, regionally in the spinal cord, and globally in the brain. Modern brain imaging techniques have shown that acupuncture actually changes patterns of brain activity in areas associated with pain processing. It's as if the treatment helps reorganize how the brain interprets and responds to pain signals. The applications extend far beyond back pain. For people with diabetic neuropathy, a condition where high blood sugar damages nerves, causing burning, tingling, and shooting pains in the hands and feet, acupuncture has shown remarkable promise. Patients report not just reduced pain, but improved physical activity and better sleep. Many are also able to reduce their dependence on oral pain medications, which is particularly important for diabetic patients who often have to take multiple medications for various aspects of their condition. One of the most compelling applications of acupuncture is in cancer care. Cancer patients face a unique challenge. They're dealing not just with pain from the disease itself, but also with the side effects of treatments like chemotherapy and radiation. Traditional pain medications can sometimes interfere with cancer treatments or cause additional side effects that compound the problem. Acupuncture offers a different approach. For cancer patients undergoing chemotherapy, acupuncture can significantly reduce nausea and vomiting, side effects that can be so severe they force patients to delay or discontinue treatment. For those receiving radiation therapy for head and neck cancers, acupuncture can help address xerostomia, the dry mouth condition that results from damage to salivary glands. In one study of patients with radiation-induced dry mouth, 68% of those receiving traditional acupuncture experienced increased salivary flow compared to 50% of those receiving a placebo treatment. What's particularly encouraging is that these improvements often persisted even after acupuncture treatment ended, suggesting that the therapy was helping to restore normal function rather than just temporarily masking symptoms. But perhaps one of the most intriguing applications is for breathlessness in cancer patients. In a study of 20 patients with breathing difficulties related to their cancer, 70% experienced marked improvement in their symptoms after acupuncture treatment. Brain imaging showed changes in patterns associated with breathlessness, relaxation, and anxiety that lasted for more than 6 hours after treatment. The safety profile of acupuncture, when performed by properly trained practitioners, is impressive. In a comprehensive study tracking nearly 400 patients over more than 1,400 treatment sessions, serious adverse events were extremely rare. The most common side effects were minor and temporary, things like slight bleeding when needles were removed, minor bruising, or temporary tiredness after treatment. This brings up an important point about acupuncture in modern pain management. It's not positioned as a replacement for all other treatments, but rather as a valuable tool that can be integrated with other approaches. For many patients, acupuncture works best as part of a comprehensive pain management strategy that might also include exercise, medication, psychological support, and other interventions. The research also reveals that different types of acupuncture work better for different conditions. Traditional needle insertion without electrical stimulation may be optimal for some patients, while others benefit more from the combination of needles and electrical stimulation. Some conditions respond better to frequent treatments over a shorter period, while others benefit from maintenance treatments spread out over longer time periods. What's particularly exciting about current acupuncture research is that it's helping to bridge the gap between traditional medicine and modern neuroscience. As we better understand how acupuncture affects pain processing in the nervous system, we're gaining insights that may help us develop new treatments and better understand pain itself. Sometimes, despite our best efforts with exercise, acupuncture, medications, and other conservative treatments, chronic pain persists at levels that significantly impact quality of life. For these challenging cases, modern medicine offers more aggressive interventions, including a category of treatments called neurolysis. While these approaches are more invasive, understanding them helps complete our picture of comprehensive pain management. Neurolysis involves deliberately interrupting nerve pathways that transmit pain signals. Now, before you recoil at the idea of intentionally damaging nerves, consider this. For some patients, this represents the difference between a life dominated by pain and a life where pain is manageable. The decision to pursue neurolysis isn't taken lightly. It's typically reserved for situations where several criteria are met. The pain is severe and persistent. Conservative treatments have been thoroughly tried without success. The pain has a significant impact on quality of life, and the patient has been carefully evaluated to ensure they're a good candidate for the procedure. One of the most important considerations is life expectancy. This might sound harsh, but it's actually a compassionate calculation. Neurolysis effects typically last about 3 to 6 months, though this can vary considerably. For someone with terminal cancer who's experiencing severe pain that's not responding to other treatments, a procedure that provides 3 to 6 months of significant relief can be life-changing. It can mean the difference between spending their remaining time heavily sedated on high-dose medications versus being alert and comfortable with family. The types of pain that respond best to neurolysis are those that are well localized and can be precisely identified by the patient. Think of it like this. If you can point to exactly where your pain is and describe it consistently, neurolysis is more likely to be successful. Problems arise when treatments need to cover multiple areas or when pain is vague and difficult to pinpoint. Interestingly, visceral pain, pain from internal organs that's often described as deep, aching, or cramping, often responds well to these interventions despite being more diffuse. This is because the nerve pathways for visceral pain are often more predictable and accessible than those for some types of surface pain. The techniques for neurolysis vary depending on the location and type of pain. Chemical neurolysis uses substances like alcohol or phenol to interrupt nerve function. Thermal techniques use heat, radiofrequency, or cold, cryotherapy, to achieve similar results. Each approach has its advantages and limitations. Cryotherapy, which uses extreme cold to temporarily interrupt nerve function, tends to cause less permanent damage to nerve architecture. This makes it a preferred option when patients have longer life expectancies because if the pain returns, the procedure can often be repeated. Radiofrequency techniques use heat to create precise, controlled lesions in nerve tissue. These procedures can often be performed with sophisticated imaging guidance, allowing for extremely precise targeting of specific nerve pathways. What's particularly important to understand about neurolysis is that it's not a one-size-fits-all approach. The technique chosen depends on multiple factors: the type of pain, its location, the patient's overall condition, their life expectancy, and their personal goals and values. For patients in rural areas or developing countries where high-tech pain management resources may not be available, neurolysis can sometimes provide relief that would otherwise require expensive ongoing treatments. A single procedure that provides months of relief might be more practical than treatments requiring frequent clinic visits or complex medication regimens. However, neurolysis also comes with risks and limitations. Because it involves deliberately damaging nerve tissue, there's always the possibility of unintended effects. In some cases, patients might experience numbness or altered sensation in areas served by the treated nerves. Rarely, more serious complications can occur. This is why patient selection is so crucial. Ideal candidates are typically those with discrete, well-defined pain that hasn't responded to conservative treatments, who understand both the potential benefits and risks, and whose life situation makes the risk-benefit calculation favorable. The psychological aspects of neurolysis are also important. For many patients, reaching the point where neurolysis is being considered represents a significant milestone in their pain journey. They may have tried numerous other treatments, and the idea of a more invasive procedure can be both hopeful and frightening. Careful counseling before these procedures involves not just explaining the technical aspects, but also helping patients understand what realistic expectations should be. Neurolysis rarely eliminates pain completely. The goal is typically to reduce pain to more manageable levels. Success might mean going from a pain level of 8 out of 10 to a level of 3 or 4, still present, but no longer dominating daily life. The timing of neurolysis is also crucial. Performed too early in a patient's pain journey, it might provide relief, but also prevent them from exploring less invasive options that could have been equally effective. Performed too late, patients might have suffered unnecessarily, or their overall condition might have deteriorated to the point where they're not good candidates for the procedure. Interestingly, some of the most successful neurolysis procedures are performed at bedside for non-ambulatory patients. This highlights an important principle in pain management. Sometimes the most sophisticated approach isn't the most high-tech one, but rather the one that's most appropriately matched to the patient's specific situation and needs. As we move deeper into the 21st century, some of the most exciting developments in pain management come from the intersection of technology and neuroscience. We're talking about treatments that sound like science fiction, implanted devices that can electrically stimulate the spinal cord, electrodes placed deep in the brain, and pumps that deliver medication directly to the nervous system. But these aren't experimental concepts. They're established therapies helping thousands of patients live better lives. Let's start with spinal cord stimulation, or SCS. Imagine a pacemaker for pain, a sophisticated device that sends carefully calibrated electrical pulses to the spinal cord, essentially jamming pain signals before they can reach the brain. This isn't a new concept, but the technology has become remarkably refined. The ideal candidate for spinal cord stimulation is someone with focal neuropathic pain, typically pain that's localized to one or two extremities or confined to the trunk. The most common application is for something called failed back surgery syndrome, an unfortunately common condition where patients continue to experience significant pain after back surgery. Now, the name failed back surgery syndrome might sound discouraging, but it's important to understand that it doesn't necessarily mean the surgery was performed incorrectly. Sometimes, despite technically successful procedures, pain persists due to scar tissue formation, ongoing nerve irritation, or other factors that weren't fully correctable with surgery. For these patients, spinal cord stimulation offers remarkable hope. Studies show success rates of about 60 to 65% for achieving more than 50% pain reduction over 5 years. That means that roughly 2/3 of carefully selected patients experience significant, sustained relief from a condition that had previously been dominating their lives. The procedure involves implanting thin electrical leads either through a needle, percutaneous approach, or through a small surgical incision. These leads are positioned in the epidural space, the same area where epidural anesthesia is given during childbirth, and connected to a pulse generator that's typically implanted under the skin near the abdomen or buttock. What's fascinating about spinal cord stimulation is that patients can control their own treatment. The pulse generator can be adjusted using an external remote control, allowing patients to increase or decrease stimulation as needed throughout the day. Many patients describe the sensation as a gentle tingling or buzzing that replaces their pain. But spinal cord stimulation isn't the only game in town. For patients whose pain is limited to the distribution of a single peripheral nerve stimulation offers a more targeted approach. This is particularly effective for conditions like occipital neuralgia, severe headaches that originate from irritation of nerves at the base of the skull. Now let's venture into even more sophisticated territory: deep brain stimulation for pain. This involves placing electrodes deep within specific brain structures that are involved in pain processing. It sounds dramatic, and it is, but for carefully selected patients with intractable pain that hasn't responded to other treatments, it can be life-changing. Deep brain stimulation targets different brain regions depending on the type of pain. For nociceptive pain, the type that results from tissue damage or inflammation, stimulation of the paraventricular periaqueductal gray matter often works best. This region is rich in the body's natural opioid systems, so stimulation may work by enhancing the brain's own pain-fighting mechanisms. For neuropathic pain that results from nerve damage, stimulation of the sensory thalamus is often more effective. The thalamus acts like a relay station for sensory information traveling to the brain, so stimulation here can interrupt abnormal pain signals. The success rates for deep brain stimulation are encouraging but variable. About 60 to 80% of patients who undergo a trial period experience enough relief to justify permanent implantation, and 25 to 35% maintain significant long-term pain relief. Some centers report success rates as high as 80%, though these outcomes depend heavily on careful patient selection. An alternative to deep brain stimulation is motor cortex stimulation, which involves placing electrodes on the surface of the brain over the motor cortex, the area that controls movement. This might seem counterintuitive for treating pain, but research has shown that stimulating motor areas can significantly affect pain processing. Motor cortex stimulation has some advantages over deep brain stimulation. Because the electrodes are placed on the brain surface rather than deep within brain tissue, the procedure carries lower risks of serious complications. It's particularly effective for certain types of facial pain, including trigeminal neuropathy. About 50 to 70% of patients who receive motor cortex stimulation experience significant long-term pain relief. The procedure works best for patients who haven't lost sensation in the painful area, an important consideration when selecting candidates. Now, let's talk about a completely different technological approach: neuraxial drug infusion. Instead of using electricity to modify pain signals, this approach involves delivering pain medications directly to the nervous system through implanted pumps and catheters. The concept is elegant. Instead of giving pain medication by mouth or injection, where it has to travel through the entire body before reaching pain receptors in the nervous system, why not deliver it directly to where it's needed? An implanted pump can deliver tiny amounts of medication directly to the spinal fluid, where even small doses can be extremely effective. This approach is particularly valuable for cancer-related pain, where the goal is maximum pain relief with minimum side effects. When morphine is delivered directly to the spinal cord, Patients may need 100 times less medication to achieve the same pain relief they would get from oral doses. This dramatic reduction in dose means far fewer side effects like sedation, nausea, or constipation. The pumps used for neuraxial drug infusion are marvels of engineering. They're about the size of a hockey puck, implanted under the skin, and can be programmed to deliver precise doses at specific times. Most pumps need to be refilled every few months through a simple procedure in the doctor's office. But here's something crucial to understand about all these high-tech approaches. They're not first-line treatments. They're reserved for patients who have exhausted more conservative options and who meet specific criteria. The decision to pursue any of these interventions involves careful consideration of factors like life expectancy, type of pain, previous treatment responses, and individual patient factors. The selection process typically involves psychological evaluation as well as medical assessment. Living with an implanted device requires adaptation and ongoing management, so patients need to be prepared for the realities of long-term device maintenance, including periodic replacements and potential complications. What's particularly exciting about this field is how rapidly it's advancing. Newer spinal cord stimulation systems can deliver more sophisticated patterns of stimulation. Some systems can sense the patient's activity level and automatically adjust stimulation accordingly. Others can deliver different types of stimulation to different areas simultaneously. Research is also exploring closed-loop systems that could monitor pain levels in real time and automatically adjust treatment. Imagine a device that could detect when your pain is increasing and respond immediately with appropriate intervention. That's the direction this technology is heading. Want to learn more about the future of medicine and how technology is transforming health? Check out Scoob, your AI-powered podcast studio app that explores breakthroughs in technology, science, and the betterment of mankind. Download Scoob from the App Store or Play Store and stay at the forefront of innovation in health and wellness. Not all pain is created equal, and as our understanding of pain mechanisms becomes more sophisticated, we're developing increasingly targeted approaches for specific pain conditions. This segment of our journey takes us into the realm of precision pain medicine, where treatment is tailored not just to the individual patient, but to the specific mechanisms driving their particular type of pain. Let's start with myofascial pain syndrome, a condition that perfectly illustrates how understanding pain mechanisms can lead to targeted treatments. Myofascial pain involves tight, tender muscles with what are called trigger points, specific spots that, when pressed, can cause both local pain and referred pain to other areas of the body. If you've ever had a knot in your shoulder that somehow caused headaches, or a tight spot in your back that made your arm ache, you've experienced myofascial pain. What makes this condition particularly interesting is that the trigger points, those tender spots and muscles, seem to have their own abnormal electrical activity that can be measured and targeted. The primary treatment for myofascial trigger points is injection therapy, but it's not as simple as just sticking a needle anywhere in the muscle. The technique requires precise identification of the trigger point and careful needle placement to elicit what's called a local twitch response, a brief contraction of the muscle fibers that indicates you've hit the right spot. Here's where it gets interesting. Research has shown that the substance injected matters less than the mechanical effect of the needle itself. Studies comparing trigger point injections using local anesthetic versus simple saline solution found similar effectiveness for both. This led to the development of dry needling, a technique that uses thin, solid needles, similar to acupuncture needles, inserted directly into trigger points without injecting any substance at all. The success of dry needling has led to some fascinating insights about pain mechanisms. It appears that the mechanical stimulation of abnormal trigger point tissue helps restore normal function, regardless of whether any medication is introduced. This suggests that some types of chronic pain may involve localized tissue dysfunction that can be reset through precise mechanical intervention. For patients with myofascial pain who don't respond adequately to trigger point treatments alone, the approach often expands to address contributing factors. Many people with chronic myofascial pain also have psychological distress, sleep disturbances, and functional limitations that both contribute to and result from their pain condition. This is where comprehensive pain management becomes crucial. A patient might receive trigger point injections for immediate relief, but also benefit from medications like tizanidine, a muscle relaxant that's particularly effective for chronic myofascial pain and can also help with sleep problems when given at bedtime. Now let's shift to a completely different type of pain, chronic abdominal pain. This presents unique challenges because the abdomen contains multiple organ systems, and pain from different sources can feel remarkably similar to patients. The key to managing chronic abdominal pain lies in understanding that it's not just about finding the source of pain, it's about understanding how pain signals from the abdomen are processed and how they can become amplified or distorted over time. Afferent nerves, the nerves that carry sensory information from the abdomen to the brain, can become sensitized through various mechanisms. Inflammatory processes can make these nerves hyper-responsive, so that normal digestive processes that shouldn't cause pain start triggering pain signals. What's particularly relevant is how stress affects abdominal pain perception. Stress can trigger the release of substances from immune cells called mast cells, which can further sensitize pain nerves. This creates a vicious cycle where stress increases pain, pain increases stress, and both factors work together to maintain and amplify the problem. The diagnostic approach to chronic abdominal pain has to balance thoroughness with practicality. While extensive testing might seem like the obvious approach, the reality is that many cases of chronic abdominal pain don't have a clear structural cause that shows up on scans or lab tests. This doesn't mean the pain isn't real. It means that the pain may be related to functional problems with how pain signals are processed, rather than structural damage that's visible on imaging. Understanding this distinction is crucial for both patients and healthcare providers because it shifts the focus from finding and fixing damage to managing and modulating pain processing. The treatment approach for chronic abdominal pain often combines several strategies. Medications might include not just traditional pain relievers, but also drugs that affect how nerves process signals. Things like gabapentin for neuropathic pain components, or tricyclic antidepressants that can modulate pain processing at the spinal cord level. Non-invasive therapies play a particularly important role in abdominal pain management. Cognitive and behavioral therapies help patients develop better self-control over their pain, understand the relationships between stress and symptoms, and engage in activities that promote healing while avoiding behaviors that perpetuate chronic pain. What's fascinating about both myofascial pain and chronic abdominal pain is how they illustrate the importance of the biopsychosocial model of pain. The bio component involves the physical mechanisms, trigger points, sensitized nerves, inflammatory processes. The psycho component includes how thoughts, emotions, and beliefs about pain affect the pain experience. The social component encompasses how pain affects relationships, work, and daily functioning. Effective treatment addresses all three components. For a patient with myofascial pain, this might mean trigger point injections for the biological component, stress management techniques for the psychological component, and workplace modifications for the social component. For someone with chronic abdominal pain, it might mean medications that target nerve sensitization, cognitive therapy to address catastrophic thinking about symptoms, and family counseling to help loved ones understand how to be supportive without inadvertently reinforcing illness behaviors. This precision approach to pain management represents a major shift from the traditional model of trying to find a single treatment that works for everyone with a particular diagnosis. Instead, we're moving toward understanding that even patients with the same diagnosis might have different mechanisms driving their pain, and therefore might benefit from different treatment approaches. The future of precision pain medicine likely lies in developing better ways to identify which specific mechanisms are driving an individual patient's pain, and then selecting treatments that target those specific mechanisms. This might involve genetic testing to understand how a patient metabolizes certain medications, advanced imaging to identify specific patterns of brain activation associated with different types of pain, or sophisticated assessments of psychological and social factors that influence pain processing. Pain isn't just a medical condition, it's a deeply human experience that's influenced by factors like gender, age, culture, and individual psychology. Understanding these human factors is crucial for providing effective, compassionate pain care. This is where the science of pain management intersects with the art of understanding people. Let's start with one of the most significant factors: gender. The differences between how men and women experience, report, and respond to pain are profound and have important implications for treatment. Women are significantly overrepresented in chronic pain clinics compared to their representation in the general population. This isn't necessarily because women experience more pain than men, but rather because they're more likely to seek medical care for pain and to report pain symptoms to healthcare providers. This difference in treatment-seeking behavior reflects broader patterns in healthcare utilization. Women generally seek medical care earlier and more frequently for various health issues, while men often delay seeking treatment until symptoms become severe. The result is that when men do present to pain clinics, they typically have higher levels of pain, disability, and functional impairment compared to men with similar conditions in community settings. But the gender differences go far beyond just whether someone seeks treatment. The actual response to pain medications differs significantly between men and women. For example, ibuprofen, one of the most commonly used pain medications, shows gender-specific effects. In experimental studies, ibuprofen effectively reduced pain thresholds in men, making them less sensitive to painful stimuli. In women, however, ibuprofen showed no significant difference from placebo in terms of pain threshold changes. Opioid medications also exhibit striking gender differences. Mu-opioids like morphine generally provide better pain relief in men, while kappa opioids like butorphanol are more effective in women. When researchers studied postoperative pain in a large group of patients, they found that women required 30% more morphine than men to achieve comparable pain relief. Modern brain imaging has revealed fascinating insights into these differences. Positron emission tomography studies show distinct gender differences in how mu-opioid receptors in the brain activate in response to pain. Men and women literally process pain differently at the neurochemical level. The gender differences extend to non-pharmacological treatments as well. Attention-focusing techniques, where patients concentrate on the sensations of pain rather than trying to distract from them, significantly reduce pain scores in men but show no effect in women. On the other hand, women often respond better to visualization and imagery techniques during relaxation training, while men tend to prefer external monitoring devices like biofeedback equipment. These findings have profound implications for personalizing pain treatment. A pain management strategy that works well for men might be less effective for women, and vice versa. The most effective approach likely involves tailoring not just medication choices, but also psychological interventions and coping strategies to gender-specific preferences and responses. Now let's consider another crucial factor: age. Managing pain in elderly patients presents unique challenges that go far beyond simply adjusting medication doses for older bodies. Older adults face a perfect storm of factors that complicate pain management. They're more likely to have multiple medical conditions, take multiple medications, and have age-related changes in how their bodies process drugs. They're also more susceptible to medication side effects and more likely to experience serious complications from those side effects. The start low and go slow principle is fundamental in geriatric pain management, but it needs to be balanced against the risk of undertreating pain. The goal is to find the sweet spot where pain is adequately controlled without causing unacceptable side effects. Opioid management in the elderly requires particular expertise. Older patients metabolize these medications more slowly, so effects last longer and accumulate more readily. What might be a safe dose for a younger person could cause dangerous sedation or breathing problems in an elderly patient. Conversely, some older patients who have been taking opioids for years may require surprisingly low doses for good pain control. As anxiety about pain management decreases and other aspects of comprehensive care improve, the actual medication requirements often decrease as well. One of the most challenging aspects of pain management in older adults is distinguishing between medication side effects and other medical problems. Deep sleep following relief of chronic pain might be misinterpreted as excessive sedation from morphine. Cognitive changes that develop during hospitalization might be attributed to pain medications when they're actually due to infections like pneumonia or urinary tract infections. Dementia adds another layer of complexity. About 5% of people over 65 have some form of dementia, rising to more than 20% after age 85. Patients with dementia may not be able to report their pain effectively, may forget that they've received pain medication, or may become confused about their symptoms. The challenge is compounded by the fact that hospitalization itself can worsen confusion in elderly patients, even those without underlying dementia. A patient who was functioning well at home might develop significant disorientation simply from being in an unfamiliar environment, regardless of their pain medications. Adjuvant medications, drugs that aren't primarily pain relievers but can help with pain, play a particularly important role in elderly patients. Medications like gabapentin for neuropathic pain or low-dose tricyclic antidepressants for certain types of chronic pain can often allow for lower opioid doses while maintaining good pain control. However, these medications also require careful monitoring in older adults. Tricyclic antidepressants can cause orthostatic hypotension, dangerous drops in blood pressure when standing, and anticholinergic effects that can contribute to confusion, constipation, and urinary retention. The social aspects of pain management become particularly important in older adults. Many elderly patients live alone or have limited social support, which can affect their ability to manage complex medication regimens or implement non-pharmacological pain management strategies. For patients in nursing homes or assisted living facilities, pain management often requires coordination between multiple caregivers who may have different levels of training and experience with pain assessment and management. Quality assurance in these settings needs to include protocols for pain assessment and management to ensure that residents receive appropriate care. The spiritual dimension of pain also becomes more prominent in older adults. Many elderly patients have well-developed spiritual frameworks for understanding suffering and may draw on religious or philosophical beliefs to cope with chronic pain. Effective pain management in this population often involves understanding and respecting these beliefs while providing appropriate medical care. What emerges from considering these human factors is that effective pain management can never be purely technical. It requires understanding each patient as a unique individual with their own biology, psychology, social circumstances, and life experiences. The future of pain management lies not just in developing more sophisticated technologies or medications, but in better understanding how to integrate these advances with personalized approaches that account for the full range of human factors that influence pain experience. As we near the end of our journey through the landscape of modern pain management, it's time to step back and consider how all these different approaches, from simple exercise to sophisticated brain stimulation, fit together into comprehensive, personalized treatment strategies. One of the most important insights from our exploration is that effective pain management is rarely about finding a single magic bullet. Instead, it's about understanding pain as a complex, multifaceted experience that often requires multiple interventions working in concert. Consider a patient with chronic low back pain following failed spine surgery, a condition we've touched on several times. Their comprehensive treatment plan might begin with a foundation of physical therapy and graded exercise to address muscle weakness and movement dysfunction. This addresses the physical deconditioning that often accompanies chronic pain. At the same time, they might benefit from cognitive behavioral therapy to address pain-related fears and catastrophic thinking patterns. Fear of movement often perpetuates disability long after initial healing should have occurred, so psychological interventions become a crucial component of physical recovery. For breakthrough pain episodes, they might use carefully prescribed short-acting medications, while trigger point injections address specific areas of muscle tension and spasm. If conservative measures aren't sufficient, they might be a candidate for spinal cord stimulation, which could dramatically reduce their baseline pain levels. Throughout this process, attention to sleep hygiene, stress management, and maintaining social connections supports overall recovery. Family education helps ensure that loved ones understand how to be supportive without inadvertently reinforcing pain behaviors. This comprehensive approach reflects our growing understanding that chronic pain is not just a symptom of tissue damage, but a complex condition that affects, and is affected by, multiple body systems and life domains. The gate theory of pain that we discussed early in our journey provides a framework for understanding why multidisciplinary approaches work. When multiple interventions simultaneously activate different mechanisms for closing pain gates, Physical exercise activating large nerve fibers, psychological interventions engaging brain-level gating mechanisms, medications affecting neurotransmitter systems. The cumulative effect can be much greater than any single intervention alone. This principle explains why some of the most successful pain management programs combine seemingly unrelated approaches. A patient with fibromyalgia might benefit from low-impact aerobic exercise, warm water therapy, sleep medications, antidepressants that affect pain processing, stress reduction techniques, and support groups. Each intervention targets different aspects of the complex pathophysiology underlying their condition. The field is also moving toward more sophisticated ways of matching treatments to individual patients. Pharmacogenetic testing, analyzing how a patient's genetic makeup affects drug metabolism, is beginning to inform medication choices. Some people are rapid metabolizers of certain drugs and need higher doses or more frequent dosing, while others are slow metabolizers who may experience toxicity at standard doses. Advanced brain imaging is revealing individual differences in pain processing that may help predict which patients will respond to specific treatments. Functional MRI studies can identify patterns of brain activation associated with different types of pain and different treatment responses. The integration of technology into pain management is accelerating rapidly. Smartphone apps can help patients track pain patterns, medication effects, and functional improvements over time. Wearable devices can monitor activity levels, sleep quality, and physiological indicators of stress and recovery. Telemedicine is expanding access to specialized pain management, particularly important for patients in rural areas or those with mobility limitations. Virtual reality is being explored as a tool for pain distraction, relaxation training, and even exposure therapy for movement-related fears. Artificial intelligence is beginning to analyze complex patterns in patient data to predict treatment responses and identify optimal treatment combinations. Machine learning algorithms can process vast amounts of information about patient characteristics, pain patterns, and treatment outcomes to generate personalized treatment recommendations. But perhaps the most important development is the growing recognition that effective pain management requires a fundamental shift in how we think about pain itself. The traditional biomedical model that views pain as a simple signal of tissue damage is giving way to a more sophisticated understanding of pain as a complex experience influenced by biological, psychological, and social factors. This shift has profound implications for how we approach treatment. It means that asking, "What's wrong with you?" is less important than asking, "What's your experience of pain, and how is it affecting your life?" It means that success is measured not just by reductions in pain intensity scores, but by improvements in function, mood, sleep, relationships, and overall quality of life. The future of pain management lies in continuing to develop this more holistic, personalized approach. This means training healthcare providers to understand not just the technical aspects of pain treatment, but also the human aspects, how to communicate effectively about pain, how to address patient fears and misconceptions, how to support behavior change, and how to coordinate care across multiple disciplines. It also means continuing to research not just which treatments work, but for whom they work, under what circumstances, and in what combinations. The goal is to move beyond trial and error approaches to more systematic, evidence-based methods for matching patients to optimal treatment strategies. Research is also exploring how to prevent the transition from acute to chronic pain, identifying early warning signs and intervening before pain becomes entrenched. This preventive approach could dramatically reduce the human and economic costs of chronic pain. Finally, there's growing recognition that effective pain management requires addressing social determinants of health, factors like poverty, education, social support, and access to health care that profoundly influence pain outcomes. The most sophisticated medical treatments may have limited effectiveness if patients lack the resources and support needed to implement them successfully. As we conclude our journey through the world of pain management, I hope you've gained not just knowledge, but also a sense of hope and possibility. Pain, whether acute or chronic, is one of the most challenging problems in medicine, but it's also an area where remarkable progress is being made. For those of you living with chronic pain, I hope this podcast has given you new perspectives on potential treatments and renewed hope for better management of your condition. For those of you who are healthcare providers, I hope it's reinforced the importance of comprehensive, multidisciplinary approaches to pain care. And for all of us, I hope it's highlighted that pain management is not just a medical issue, but a fundamentally human one that requires compassion, understanding, and recognition of the full complexity of human experience. The field of pain management continues to evolve rapidly, with new discoveries, new technologies, and new understanding emerging regularly. What remains constant is the commitment to reducing suffering and improving quality of life for the millions of people affected by chronic pain. Thank you for joining me on this journey into the science and hope of pain management. Remember, if you're facing chronic pain, you're never alone, and the future holds more promise than ever before. For more inspiring stories and expert insights on health, science, and well-being, explore Scoob, the AI-powered podcast studio designed to feed your curiosity and support your journey. Download from the App Store or Play Store today. Until next time, this has been The Empowerment Hour. I'm your host, Joss Blake. Take care of yourselves, and remember, sometimes the most profound healing begins with simply understanding that you are understood.